Uremic cardiomyopathy. Uremic cardiomyopathy is a multifactorial disease which is a significant burden in patients with end-stage renal disease. It is associated with arrhythmia, cardiac failure, and sudden cardiac death. Uremic cardiomyopathy is characterized by diastolic dysfunction, left ventricular hypertrophy, myocardial fibrosis in patients with CKD. In end-stage renal disease, the risk of cardiovascular disease is 15 to 30 times more than the general population. The left ventricular hypertrophy is seen in 70% of the end-stage renal disease patient. Sudden cardiac death is the cause of 40% of all death in end-stage renal disease on hemodialysis. The pathophysiology of uremic cardiomyopathy. There is traditional risk factors and uremic risk factors. Traditional factors are diabetes, hypertension, dyslipidemia, older individuals, physical inactivity, and smoking. The uremic factors are indoxyl sulfate, picrosyl sulfate, beta-2 microglobulin, and homocysteine. CKD mineral bone disease, anemia, inflammation, cardiotonic steroids, endothelial dysfunction, all involved in the pathophysiology of uremic cardiomyopathy. This uremic state contributes to the left ventricular hypertrophy. The accumulation of parathyroid hormone, endothelin, TNF-alpha, interleukin-1, interleukin-2, cardiotonic steroids act on cardiac myocytes and can finally result in uremic cardiomyopathy. Oxidative stress, inflammation, endothelial dysfunction results in heart failure and worsen atherosclerosis. Vascular calcification, erythropoietin resistant, increased hepcidin, decreased iron absorption happen due to the inflammatory state in CKD. Alpha-klotho and vitamin D preserves the endothelial integrity. There is a decrease in alpha-klotho and vitamin D in CKD patient. FGF23 and phosphate will damage the endothelial lining. The microvascular endothelial dysfunction can cause diastolic dysfunction. Carnitine deficiency, insulin resistant, FGF23, alpha-klotho deficiency all contribute to the pathogenesis of uremic cardiomyopathy. The diagnosis, we can do a ECG. Left ventricular hypertrophy can be seen. In echo, there can be left ventricular hypertrophy, left ventricular dysfunction, and increased left ventricular mass. Cardiac MRI can be done. T1 and T2 mapping can be done to differentiate uremic cardiomyopathy from other hypertrophic phenotypes. Myocardial biopsy is an invasive investigation to diagnose uremic cardiomyopathy. The treatment options are pharmacological, AC inhibitors, beta blockers, erythropoietin. Dialysis options are short-term hemodialysis and nocturnal hemodialysis can partially reverse the left ventricular hypertrophy. Renal transplantation is the surgical option which can reverse the underlying state and improve the survival.